Good morning, everyone. My name is Robin Hassler Thompson, and I'm the Executive Director of STAC, the Survive and Thrive Advocacy Center. I'd like to welcome you today to Human Trafficking Recognition, Response, and Referral. This is a program that we've worked on for some time now, and I think you'll really enjoy it. We have an amazing panel of speakers. We have many people still joining the room, so we'll take a moment and I'll do some brief introductory information for you so that we can get going really quickly. First, I've asked everybody if you'd like to say good morning in the chat. We'd love for you to do that. Please feel free to give us your name, where you're calling in or you're zooming in from, and where you're what you do, if you're part of the healthcare profession or part of the community. Also like to give you some technical info for our program today. And that's first that you'll be able to chat as well as ask questions. At the bottom of your screen with Zoom, you'll see a little chat button as well as something for Q&A. What we're going to do this morning and for this whole program is try to answer your questions online if possible. So a couple of us are going to be monitoring that chat. But we're going to try to save the bigger questions, kind of the meatier questions, for the end of the program. If there's something foundational, though, where you don't understand an acronym or there's something you need in order for you to get what's going on, please feel free to go ahead and put that question in the Q&A, and we'll try to answer it during the presentation so you've got what you need to build on what was just said. Know, too, that we're going to be having this recorded. You should know that we're really grateful to the Florida Medical Association. They are a dignity sponsor for what you see at the top of your screen, Imagining Freedom. Imagining Freedom is our organization's, the Survive and Thrive Advocacy Center's, premier fundraising and community action days event. We're doing a lot of activity. We're doing a lot of awareness building and education. And we're also doing some fun things like a local coffee shop, Red Eye, is featuring the Imagine Freedom latte. And we're really honored by that, too, because what they're doing is essentially letting businesses know that it is possible to be in an organization and in a business where all of your supply chain is trafficking-free goods and services. So what I'd like to do now is just check in with our panelists. It looks like we're all ready to go today. And again, welcome you all to this event. One more thing, this is available for continuing education credit for nurses and for dental professionals. What we'll do is give you all of the information about how you will get your CEU credits at the end. As you probably know, you have to take a quiz and an evaluation. So we'll have the links for that at the end of our program after this period. All right. And again, welcome everyone to Human Trafficking and Healthcare. I'd like to now immediately go to introducing our wonderful panel, all people that I know personally I've had the honor of working with. And let me turn it over right now to Dr. Harrison. Would you like to say good morning and hello?
Absolutely. Thank you so much, Robin. I'm so happy to be with all of you here this morning to talk about something that is near and dear to my heart. I've been involved in work related to human trafficking education and prevention for about 15 years now, I think. Dates back to when Graciela, who will introduce herself shortly, and I worked together at Refuge House, which is our local domestic violence shelter. And in the course of that collaboration, a couple of young women were sheltered who were determined to be victims of human trafficking. And it was really through the care of those women that I learned the extent of human trafficking, and then sought to make sure that medical students and residents were educated about this problem, that physicians were really able to recognize a person who might be a victim of human trafficking in the context of their clinical practice. So I've been doing that work for a number of years. A lot of my career has evolved around caring for victims of violence and abuse. And as you can see from the slide, I'm a family physician. I work at the Florida State University College of Medicine and am a consultant to the Survive and Thrive Advocacy Center.
Thank you, Suzanne. And Dr. McCord.
Good morning, everyone. My name is Jasmeka McCord. I am a first-year resident at the Joe DiMaggio Children's Hospital Memorial Healthcare System in Hollywood, Florida. I'm a graduate of Florida State University College of Medicine, where I had the privilege of being mentored under Dr. Harrison, who introduced me to this whole world of human trafficking. And I've just been learning and growing and researching since then. So it's very important to me as I'm a budding pediatrician in training, and I want to equip myself to be able to recognize and intervene with my patients and give them the guidance and assistance that they need. So very happy to be here today.
Thank you so much. Graciela, would you like to say hello?
Yes. Let me first unmute myself again. My name is Graciela Marquina. I have been working with Robin and Dr. Harrison since a long time ago. I finished my master's here in FSU, master's degree in social work. And this is my niche. I want to help. I work with survivors and impossible victims. And we create a case plan or something where they can not only survive, but thrive. I want to keep learning. I don't want to stop. I want to keep learning.
Thank you, Graciela. And it's an honor to be working with all of you. Day in and day out, I work with Graciela, and I have to tell you, she is outstanding. Let me also mention something very quickly. We're part of a local coalition, the Big Bend Coalition Against Human Trafficking, which many of you may be. And I want to just kind of give a shout out to all of you in the community. I'm seeing a lot of folks come in who are from the Department of Health, and it's really important to seek out your local coalitions. So here's our disclosures. We have none, and so we can move on to the next slide with that. So what are we going to do today? One of the things that's really important is to understand what we're talking about when we talk about what is human trafficking, especially in the healthcare setting. For this program, you're going to have information about how to do telemedicine actually in the healthcare setting with potential survivors of sex and labor trafficking. We'll talk about ways to approach the patient, what's most effective, and how to build trust. We'll also share with you connections to resources, the importance of documentation, all the reporting you have to do. And really, I think when you're done with this program, you're going to want to be, but how are you an advocate in your community, both in your professional world and personally? So here are the objectives overall, and what I would like you to think about is these are all interrelated. So as I mentioned before, we're going to be talking in detail about definitions, the legal part, and as an attorney, I'll tell you that's going to kind of be what hat I wear for this program, and know that what I found every time I've done these programs, that healthcare professionals do want to know what the legal framework is for this issue. We'll talk about the common indicators, what you might see, how you might detect both traffickers and victims of trafficking, or someone who's been trafficked even decades ago, how they might show up in your healthcare setting. Again, we'll talk about approaching the patient, essential community resources, because if I say it once, I say it a million times, that it truly does take a village to assist survivors of trafficking. We'll talk about ways to help victims and support groups like STAC that are in your own communities, and of course, the reporting issues. So why don't we start right away and talk about the definition of human trafficking? First of all, it's really important to know why this is such an important topic to us. We know that healthcare professionals might be the very first people who will identify a victim or survivor. You all have an incredible level of trust that people place in you, and that's why really we see you as essential frontline workers on this topic as well. Also, in terms of your community, you got to know that human trafficking is a crime of crimes. So when you have something as serious as this going on with someone in your patient population, you really do need to know about it. So overall, your patient outcomes will improve. you'll find better adherence to treatment plans because you'll understand what's going on with that person. And overall in the community, you'll see, increased access to safety for patients and their whole families, greater security and justice. So again, healthcare professionals really are on the cutting edge, on the front line of fortifying local communities, your workplaces, your social groups about this issue. And it's a great way for you to see how you all fit in. You might know this, that Florida, you may have heard this, Florida is third in the number of human trafficking cases in our nation. And this is according to the National Human Trafficking Hotline, and is based on the number of calls that have come into that hotline. I think since the beginning of the hotline, Florida's been in this position. California and Texas are number 1 and number 2, respectively. Florida has had almost 900 cases reported to the hotline since its inception in 2007. And know that there are lots of trends going on in our state. You can see, for example, that a lot of the activity is really clustered in some of the major metropolitan areas, as well as along some of the major arteries, transportation corridors in our state. So the I-4 corridor that cuts across the middle, I-95 down by southeast Florida, and a little bit of sprinkling around I-10 across our area in the Panhandle. Know that this is not an indication of actual trafficking cases because this issue is so clandestine, but it is an indication of, again, those people who've called into the hotline for information. Know that both, we'll talk about this, but the reports to the hotline include sex and labor trafficking, citizens, non-citizens, pretty equally divided. The basic definition of human trafficking is important for you to realize, and you'll hear this and see this referred to as the AMP model: action, means, and purpose. But know that for there to be human trafficking, any of these things could be present under the action box. So it can be a recruiter, somebody who harbors a person, or someone who moves a person or obtains that individual could be considered a trafficker. You don't have to do all those things, and there doesn't even have to be movement. You could traffic somebody in their own home, never take them out of that home, and that could constitute human trafficking. One of the buzz phrases in the law is force or fraud or coercion. So how this is done, usually a trafficker will coerce somebody, but start out initially really being very friendly, act as a benefactor, a boyfriend, a romantic partner, someone who is really there to meet the needs of an individual. They will make promises, and that's where this issue of fraud comes in, right? They'll defraud that person, make them promises, and then, of course, not keep those promises. One of the things to note about the law is both for Florida and for the U.S. law, federal law, that if someone is a minor, they do not have to be forced or defrauded or coerced. Any child who is induced or asked to commit any kind of commercial sex act is considered a victim of trafficking. In Florida, similarly, a child that is induced or asked to commit an act of labor trafficking, or I should say, be labor trafficked. And by that I mean, working in any number of different areas. We'll talk about that, in factories and fields and homes. That child doesn't have to be forced or defrauded or coerced. Because the law imputes to children, they don't have the free will to need to be forced. And then the purpose is for any kind of labor or service, a commercial sex act, involuntary servitude, the things you see on the slide here. So all three need to be present. And please understand that, very often we see people who confuse trafficking and smuggling. The best way I think to think about this is, number one, trafficking is really an act of coercion against a person. It's involuntary. The person loses their free will. If there's an act of smuggling, know that that's a crime against the border, not an individual. Smuggling, you absolutely need movement. As I said before, for trafficking, you do not. You do not even have to cross a county line for there to be trafficking taking place. And know that the commodity is the person for trafficking. The commodity is transportation. Now, one of the ways I think this gets confused a lot is sometimes you have a trafficker who will talk to an individual and say, hey, yeah, you need to get to Florida. I can help you cross that border out of Mexico into Texas, across to Florida. Absolutely. But when that person arrives in Florida, the person who did the quote smuggling says, sorry, you owe me another $10,000 and you have to work it out in this cantina or in this brothel or for me. In other words, that trafficking in the trafficker's mind knew what they were doing. They were tricking the person, promising them to get here and be scot-free when they arrived. But then that turned into an act of human trafficking because they were forcing them then to work off that additional debt in a labor situation. Something to note and to remember is that human trafficking is something that has gotten worse. We've seen trafficking cases in STAC's caseload has tripled since the onset of COVID-19. The other things we've seen is reports out of the National Human Trafficking Hotline are that online sex trafficking has exploded, of course, during 2020 when everyone was isolated. There was actually commercial transactions, both the buying and selling of people online. Additional to that is online sex acts being committed and paid for. That increased greatly. We also saw the increases of trafficking of agricultural workers. So when everything was shut down and they were considered essential workers, what we saw was people being brought into this country legitimately on visas and then exploited. We also know that traffickers have been using COVID-19 to control victims very effectively. From the outset, when they either withheld information or masks and other protective equipment that controlled victims' movement, they were also lying to them and withholding help and assistance. So again, traffickers are extremely nimble. They'll take advantage of crises. And we've also seen with the impact of people losing jobs, people being evicted now that the eviction moratorium has been raised, there's a lot more economic instability, insecurity, and so people are more desperate. And people who are economically desperate can easily fall prey to traffickers' promises of good jobs or work or other kinds of help or assistance, which they've just lost because of the economic downturn. And we've also seen that the justice system as a whole, whether you're getting a protection order or looking for assistance in the court system, that there are increasing delays. I know we've seen that here in the Second Judicial Circuit.
So now we want to discuss who is at risk. Oftentimes you might have a picture of what someone who's being trafficked looks like, or sometimes you might have no clue. And so we want to shed some light on that. Oftentimes runaways and homeless youth are at greatest risk. When you think about it, these are children or people who just don't have as much accountability as others. If you have a runaway, you might have someone who's on the loose. They're vulnerable because they're looking for shelter or clothing or food or any type of assistance so that they can get by day to day. Otherwise, you might have homeless youth who don't have anywhere to go to, who don't have a home, don't have someone who's calling them, looking for them. And so these are the greatest risk of populations that fall into trafficking, unfortunately. In addition to that, they may be exploited through a sex trade and in addition to searching for food and clothing, they may find themselves running risk of being this homeless couch surfing, right? Where you're looking for a home or you're trying to go from couch to couch, looking for a place so that you have access to our basic necessities. And unfortunately, because of this, they're a little bit more desperate in searching for those things, and traffickers take advantage of this reality. It says there that Florida is a magnet for runaways, which we spoke about, all the highway access and those different key spots throughout the state. Other at-risk youth are those with disabilities, mental illnesses, LGBTQIA, and foster care youth. And the overall arching theme is that these are like marginalized populations or oppressed, or impoverished groups or individuals. what you'll find in all of these populations is that sometimes they will resort to survival sex. And so we mentioned searching for clothing or housing or food. And when you need those things, maybe the trafficker might coerce them and say, hey, if you do this for me, then I will give you clothes, or if you in exchange for your services, I'll provide food or shelter. And so, again, these are just at-risk populations that we often see fall victim to trafficking. Also, substance abuse is an important topic to touch upon because, unfortunately, when you have people who are under the influence of substances or have addictions that they're not managing, then they may be at risk of, trying to get drugs and other things in addition to finding, for exchange of their services. So a lot of times, overall, it's any vulnerable person who may be at risk, anyone who's searching for housing, searching for drugs if they have an addiction, searching for companionship if they have no one to talk to, searching for someone who is just willing to just be a listening ear. All of these marginalized populations are at risk. And who are the traffickers? So when you think about those reasons for why victims, end up being at risk, and then oftentimes that keys you into who may be the traffickers. You might think it might be someone who's, a criminal, or someone, who may be just a certain picture that comes to your mind when you think of someone who would subject someone to this type of behavior. But as you can see on the slide, it ranges from, mom and pop people who are loving, appearing, to business professionals. Like, there is no one who may be exempt from being in the category of being a trafficker, which is important to understand. So we have families, mom and pops. Again, when you're thinking of someone who's seeking shelter and clothing and food, mom and pop operations are, more willing and are more attractive to these people. They may think, oh, I'm going there for love, I'm going there for support, and then end up in the trafficking system. More obvious may be pimps, labor subcontractors. We mentioned migrant populations. In Florida, there's a huge migrant population of people, again, coming from different regions trying to seek labor. And that's oftentimes how they get here, under the belief that, okay, you can come here and work. And sometimes the pretenses are false. They may be saying, oh, we'll give you good housing and stuff and pay you and take care of your family back at home. But when they get here, the conditions of labor are suboptimal, to say the least. You may have diplomats, business professionals. The point of this slide is to let us know that there is no look of a trafficker. It can really be anyone, and there's no hierarchy. You're not too small or large on a totem pole to be considered a trafficker.
So as Dr. Jasmeka was saying, we have some pictures here, and they could be really anyone. We have two mothers there from this area, from Florida, that slave their own children because they have problems with addictions, and then so they sold their daughters. One specific case that is very interesting that I never knew, didn't think about it until we started doing this presentation, which is this picture we have been having it for a long time ago. This one of these men that are there, he was recruiting people, women from prison. So he was sending money to the for them, for the cantinas or whatever. And then when they will leave the prison, he will recruit them to later on slave them. The young man there that he was also recruiting young gay men and put them in a company named Never Sleep, and they, he pretty much slaved the people. If you see these people, not the smug shots, if you see them on the street, you don't think that they are traffickers. So those prototypes that we have in our head, it could be really anyone. Next slide.
And so now that we have like this picture of who's at risk and who are the traffickers, and you say, why do they stay? Why would you stay in a situation that you're not, that's suboptimal? Why would you allow yourself to be subject to this type of situation when in reality there's multi-tiered why victims stay, depending on the reasons how they got involved in the first place. Some of them are subjected to violence. They may say, the trafficker may say, hey, if you do not agree to this agreement or to this plan, if you don't do what I say, I'm gonna abuse you in any way, or yourself or your family members. Oftentimes they threaten their loved ones, even if it's not themselves. They're isolated from other people who they may be able to reach out to and ask for help. Again, when you think about the runaway victim or someone who doesn't have a home, they may not be in touch with a bunch of people who they may be able to reach out to get them out of the situation. Debt bondage. We talked about how if they come across the border, they say, hey, I'm going to assist you. Let's help you. And once they get here, they say $10,000 you may owe. And now that they have this debt, they have no other way to pay it. So they may be staying because of those reasons. Or threat of exposure after smuggling or sexual exploitation, saying, hey, if you don't agree to this, I'm going to tell the authorities that this is how you got here and you're going to end up in prison. Overall, it's just a lot of manipulation involved in keeping victims here. And it's important to understand that because in our society, we have victim shaming and victim blaming. And when you think about that, we can't put the fault so much on the victims. I don't think that thinking about, judgment or putting down victims in terms of why they're staying is an appropriate thing, because again, there's a lot of reasons why they may stay. And oftentimes we'll see traumatic bonding in which, now there's a relationship that the victims may have developed with their traffickers. And now it's like, this is maybe the only person who cares for me. And it's just so many levels that are involved in victim staying. And, I think it's important for us to remember that and focus on our attention on not so much why did they stay, but how can we help them? And again, the victims are very difficult to identify because, again, a lot of different barriers that we have addressed already and will continue to address throughout the presentation.
So now we're going to kind of move into another category. So I appreciate all of that information, and I really hope that it helps you to have a better picture of who these people may be, who the patients or the clients that you're serving may be, and how complex those situations are. So we're going to move into a section where we're talking about recognition of patients who may have been trafficked, who may be at risk for being trafficked, who may be traffickers even, because there is a little bit of overlap, as we'll discuss in the coming minutes. But I just really wanted to give you, we're going to talk about common indicators, the red flags that you might look at for human trafficking. We're going to talk about how we can increase your awareness so that you are better able to identify a person who may be a victim of human trafficking in the setting that you're in, and then encourage screening as we look at patients who may be at risk for trafficking. All right, so what we do know, and I appreciate Robin's approach at the beginning in talking about why it's so important to educate healthcare providers. It is really because they trust us, and that setting is a place where we might be able to identify victims of abuse and particularly trafficking, as we're discussing this morning. However, what we know from the research is that as healthcare providers, we're not doing a particularly good job at identifying patients who may be victims of human trafficking. There was a study less than a decade ago, it was published in 2014, where they looked at women who had been sex trafficked, and they interviewed those women. And what the women told us in this study was that almost 90% of them, almost 90% of those trafficking survivors had accessed health care during the year before the survey was done. And almost 70% of those women were seen in the emergency department. Not one single patient was identified or even asked about trafficking. And it's just a travesty that, you know, we see these patients, and I'm not saying that the physicians and other healthcare providers that may have seen the patients in the emergency department didn't think about it, didn't wonder what was going on, didn't have suspicions, but they didn't have the tools that they needed to really be able to identify a patient, to ask the right questions, to begin that conversation, to know which resources to employ and to gather together, who to reach out to in the community. And so that's really what the rest of the talk is all about. We know that these patients want to be asked. We know from talking to them in person, we know that even when they are not going to tell us the truth, they want to be asked. And that simple act of asking the question may increase the likelihood that they answer the question at a later time. So it's really important that we at least ask the question when we have any suspicion. Sorry.
So missing the signs, this is exactly what we're trying to combat, right? So lack of training, and we're all walking in the right direction, trying to recognize how to recognize victims, but we're also going to talk about once you recognize them, what do you do? Because that's equally, if not more important. We talked about how there's a few healthcare providers that recognize the signs of human trafficking, or maybe you think that you know or have some type of suspicion, but you're not sure what to do next. Or most clinicians say they wouldn't know how to respond. Again, it's this overarching theme of maybe I see something that might be there. Do I not? Am I thinking about this in my head? Should I ask? Should I not ask? What is it that I'm supposed to do if I do eventually ask and the answer is yes? How do I ask? All of these contribute to why, as health professionals, we may not understand or know what to do. So that brings us into what are the barriers. As clinicians, brief interaction time with our patients, and I have experienced this firsthand, right? Oftentimes the healthcare system is set up where you get in and you get out. You have 5 minutes to interact with a patient, 10 minutes to interact with a patient, and you have this preset agenda on why they're there and what you can do and how you can get them out quickly. And while that may be efficient in one sense or lucrative in one sense, we have to think about how that is decreasing our ability to interact or intervene and identify with human trafficking victims. We're, resource and time intensive. We don't have the expertise in trying to look at, identifying correctly these victims. On the patient aspect of it, these are often, like we mentioned before, at-risk individuals from marginalized groups. They may not feel comfortable with just being forthcoming with that information, which is why Dr. Harrison mentioned, they would like to be asked, because how do you speak up about this? Or they're severely traumatized with multiple issues, complex needs, not sure if speaking up is the appropriate thing to do. If they speak up, will they, be sought out? Will they be found out by their trafficker? They're worrying about their safety. And then again, as we mentioned, American culture, hypersexualization with pornography, and the sex trade is like normalized in a sense. We've seen it in movies like Traffic or Taken, but oftentimes, we have just kind of a liberal society where it may be normal to dress in a certain way, or where it may be normal for people to have multiple sexual partners. And when we're asking, that may not raise alarms in our heads, but we have to be keen to the specific nuances that are different between day-to-day people and sexual traffic victims. So these are the things that you can look out for, that we can listen to when we're interviewing patients, that are red flags that should raise a suspicion in our head that this situation is abnormal. So you have this inconsistent or scripted history. If you're asking patients questions and they're giving you very specific answers, or the answers aren't making sense or aligning up. If you have, say, I have a bruise and it came up this way, but that mechanism of injury doesn't match this bruise, or if they're only giving you answers that seem scripted, if you ask them something off of that script, they're not sure how to answer or don't respond. If they're unable to provide the address or even the city that they may be in. And when you think about victims traveling from place to place, they may lose track of where they are and may not be familiar with an address because they really just don't know. Some of these victims may not even see daylight, and so they're not sure what season it may be in. Only maybe if weather changes might prompt them, but otherwise they may just claim to be visiting an area versus saying, oh, this is my address. We spoke about having an unusually high number of sexual partners. And again, maybe that may be a norm in our hypersexualized society. But that may be a key to other identifying factors that may make you think that this may be a victim. In addition, you may have seasonally or situationally inappropriate clothing. If it's the middle of the winter and they have on a halter top or shorts or just a tank top that may not be appropriate for the weather, these are signs that there may be something going on because they may not have access to the appropriate clothing. If they appear much, much younger than their stated age, right? We know that traffickers know that if you're saying, oh, this is a 16-year-old, that's going to raise a red flag. But if they look like if they're claiming to be 25 or 35 when they look much younger, then again, that may be a red flag. If there's a discrepancy between history and observations, if there's any type of severe trauma, doing good skin exams, looking at, exposure to areas that may be hidden by clothing, if they don't seem like they've had enough nutrition or dehydration, all the signs that we learn to look for when we're getting training as health professionals. And for those who may not be health professionals, just things that don't sit right with you. At the end of the day, if you're saying this does not seem right, this may be a red flag and may warrant further questioning.
We'd very much now like to share with you the first of two videos that will feature Dr. Harrison and Graciela in a role play situation that is a potential labor trafficking healthcare interaction, right? So this is something where we'd like you to think about, number one, is this or is this not trafficking? What are some potential indicators that you might be seeing from the patient? How did you see, say, the Dr. Harrison's inquiries about trafficking? Did you see them as helpful? Did you see her start to build trust? And just because this is telehealth, and I'll tell you, we developed this video last December. So this was really pre-vaccine. You'll not see a lot of discussion of vaccines. So don't think about it as exactly what the situation is today. But really, as I look back, it has remained pretty evergreen, even though we're approaching a year out. Note too that this is a situation where just because it's telehealth, it doesn't mean that it's not appropriate in other situations face to face, because you'll see interactions between the physician and the patient that you could do no matter where you are, no matter how you interact with your patients, whether it's at a clinic, whether it's in an ER or any other kind of healthcare setting. So what we'd like to do is show you this video. It's about 15 minutes. We'll ask you some questions. We'll ask you to chat in your reactions and also get some feedback from both Graciela and Dr. Harrison about how they felt when they were doing this and the impact of this interaction. So let's go ahead and show the video.
Good morning, Ernestina.
Good morning.
How are you?
Fine.
I'm Dr. Harrison, and I'm here to conduct a telehealth visit with you today. Do I have your permission to continue?
Yes.
Thank you. And are you able to safely talk with me this morning?
Yes.
Thank you. can I get your full name and age?
Ernestina Mejia, 46.
Thank you so much. I just want to confirm. Now, I'm also going to be taking a few notes while we speak. Is that okay with you?
Yes.
Is there someone there with you, Ernestina?
No.
No? Okay. All right. All right. Can I find out why you wanted to have a visit today? What is the reason for your healthcare visit?
My fingers, I think I broke them.
Oh, I'm so sorry to hear that.
My body aches, and I need to go back to work.
Okay. So are you going to need a note for work? Is that your employer that's standing beside you?
Yes.
Okay. All right. So you want to talk about your fingers, your body aches, you're anxious to get back to work, and I see that you have your employer there with you during this visit. Is it okay to continue with him here?
Yes.
Okay. All right. All right. So let's start with your fingers, if we may. Do you remember when they started to hurt?
I was working, and it just, I don't know what I did. It kind of, I think I broke them. I don't know. Can you give me a Tylenol or something?
I can give you something, but let's try to figure out what's happening first, okay? All right, so is this your right hand or your left hand?
My right hand.
Can you hold up your right hand up like this for me? And show me which fingers you're talking about.
This one and this one.
Okay, and can you turn your hand around like this? And can you point to exactly where it hurts on your fingers?
Here.
Okay.
And here.
All right, okay. So it's your right hand. All right, and which day did this happen?
Yesterday.
Yesterday, okay. And have you done anything to try to make it feel better?
No.
No. Did you use any ice?
No.
Okay. Did you take any Tylenol or ibuprofen?
No.
Okay. And do you feel like your fingers are swollen?
Yes.
Are they bruised?
A little bit.
Okay, all right. Does it hurt to touch them like this? When you do this, does it hurt?
Yes.
Okay. And do you remember exactly how this happened? How you had the accident with your hand? What were you doing?
I was working in the field, and I went like this, and I was rushing, and then I don't know what I did.
Okay. Did you keep working after it happened?
Yes.
Okay. And if I were to ask you about the pain, with 0 being no pain at all and 10 being the worst pain you could possibly imagine, how much pain do you have right now?
8.
8. Okay. Thank you. Ernestina, there are a few questions I'd like to ask with you alone. Do you think you could ask your employer to leave the room? Sir, may I speak to you?
No, I don't think so.
You don't want to talk to me, or you don't want to leave the room?
I'd rather not talk, but I suppose I could leave the room.
Thank you so much. I really appreciate it. Ernestina, has he left?
Yes.
Okay. Now, can you tell me again what happened with your hand?
The other, are you going to tell my boss?
No,
Oh,
this is your health care. He has nothing to do with it.
because they are going to pay for it and I need to pay them back.
Well, actually,
So
you
if-
don't. Ernestina, did this happen while you were working? Okay, then it's your employer's responsibility to pay for this, not yours. Did you know that?
No,
Okay. Well, we can help you with some of those details after we figure out what's going on with your hand. But I think we might want to get an X-ray. Do you think you could go to an X-ray facility and get just a quick picture taken of that hand?
but who's going to pay? Or is he going to pay? Because I need to pay him back.
You don't actually. Your employer's responsible, but we can talk about the payment later. I need to see if it's broken,
Okay.
because that will change what we decide to do about it. And I'm really worried that you're worried, and I hear you. Let me come back to that in a minute, because I have someone here in the office that can help you with some of those details. Okay?
Okay.
So I'm going to come back to first I want you to hold your hand up like this. Can you do that? And can you bend your fingers like this? Okay, that really hurts, doesn't it? Okay, all right. So I want to switch gears a little bit, and I want to talk about your body aches. You said that you weren't feeling well. Can you tell me a little bit about that?
I am very afraid because I wasn't able to buy the mask last 2
Okay.
weeks, and it's very expensive. It's $8 for the blue masks,
Mm-hmm.
and it's possible that I got infected.
Okay, well, we can certainly do a test, okay? We can do that when we do the X-ray. We'll do it all at the same time, okay?
Okay.
I will make those arrangements for you.
Okay.
Have you had a fever?
I think so because my body hurts.
Okay. I'm just writing down that you have a possible fever. Do you have any shortness of breath? Do you
No.
feel like you have trouble catching your breath
At the end of the day?
at the end of the day? Okay. So basically you just feel really achy, you think you've had a fever, and you haven't been able to protect yourself against COVID the way you want to, right?
Yes.
Okay. So we
Yes.
definitely need to get you tested, okay? All right. So Ernestina, I'm a little bit worried about your work situation. Is it okay if I ask you some questions about that? All right. So how long have you been working in this place where you work right now?
3 months.
Okay. And do you live in a place that your employer owns?
Yes.
Okay. Do you have your own transportation, or do you rely on other people?
No, it's him and his brother and cousins of him.
Okay. All right. Do you have access to a cell phone or another telephone of any sort? Okay. Do you have access to your own identification documents?
I don't have papers.
Okay, that's all right. I personally don't care about that, all right? I'm not worried about it at all. So you can tell me anything you want to, anything that you feel comfortable telling me, and feel safe about that, okay? I just wanted to get a sense of how much control you had over your own life. Before you worked for this person, who did you work for?
Other person, one of his cousins in
Okay,
Georgia.
all right.
I think we were in Georgia.
Okay. How long have you been in the United States?
8 months.
Okay. I am so sorry that this doesn't sound like a very good job. It really worries me. And I'm worried that you got hurt on the job and that you've not been able to protect yourself. And I'd like to be one of the people that can help you, if you'll let me.
Yes, I have to send money. I haven't sent money to my kids for Christmas. I have to go back to work.
Okay, well, we'll see what we can do. Let me ask you a question. Are you a good memorizer? Can you memorize numbers well?
I think so.
Okay, I want to practice memorizing a phone number with you, okay? And this
Okay.
phone number that I'm going to ask you to memorize is a place where you can call and get help if you feel like you want to, okay?
But they told us not to call anyone.
Right, but you don't have to use it if you don't want to, but I want you to memorize the number in case you want it later, okay?
Okay.
Are you ready? It's 888
888
3737
3737
888.
888.
Okay. Now I'm going to say the whole thing really fast. 888-37. I'm so sorry about that. Let me try that again. 888-3737 888.
888 3737 888.
Perfect. Good job. Now let me tell you about that number, and then I'm gonna make some arrangements for you to get your X-ray and your COVID test, okay? So that we can get you feeling better. So that phone number is for a place called the Human Trafficking Hotline, because I am concerned that you are in a position where you're not being paid for your labor when you're working in the fields, and at least not being paid adequately, and that somebody's taking advantage of you. And this number can help people like you when they're ready to get help, okay? So you don't have to do anything with it. Just keep memorizing that number, okay? Thank you. Perfect. I think you've got it. All right. So I am going to have my nurse get you an order for an X-ray of your right hand, and specifically those 2 fingers that you said hurt so much. And we're going to make arrangements for you to have a COVID test at the same time, okay? You can use either Tylenol or ibuprofen for your pain and your fever, and my nurse will give you those written instructions in Spanish so that, and some samples so that you don't have to go buy them, okay? And so we're going to come to you in a mobile van to get the COVID test, do the X-ray, and then get you the Tylenol and ibuprofen, okay? It might take a day for us to be able to do all of that because, you know, we had to change things up with our pandemic. It's really, you know, it's quite a stretch to be able to do this sort of thing, but I know that you're going to have trouble with transportation, so we'll come to you. And then what I want to do right now, if that's okay with you, is I'm going to introduce you to a case manager who can talk to you about some of your needs, okay? She's in the clinic, but do you want to talk to her or not?
Is she your boss?
She is not my boss.
Oh.
She is just a colleague. She's a coworker that I work with. If you don't feel comfortable with that, I will just have you talk with my nurse and she can give you the rest of the instructions. And then if it's okay with you, I'd like to have another visit with you in a couple of days so that I can give you your test results. Would that be okay? All right.
Yes.
Okay. So great. So as soon as I have your x-ray results and your COVID test results, we will call you. We will make an appointment for us to do another telehealth visit so that I can explain I can explain your test results, and then we'll just take it from there. Okay. All right.
Thank you.
Ernestina, thank you so much for trusting me today. It's been a pleasure to talk with you, and I want to keep taking care of you if I may.
Yes, thank you.
All right.
Thank you.
Bye-bye.
Bye.
All right. Well, thank you, everybody. And thank you, particularly Dr. Harrison and Graciela, for doing this video. As you might have guessed and seen, this is something that we developed here at STAC as part of our work with the local Leon County CARES funding. So here are some questions, and I have to really give a shout out to everybody who's been so active on the chat, answering these questions and addressing these issues, identifying red flags, identifying sort of how she was possibly being controlled, issues around telemedicine. But before we go into detail on that, I'd like to throw it over to Graciela. Graciela, what was your reaction in doing this, and what about the sense you had of both being a survivor, having an interaction with a physician? Some of the comments in the chat also are about, were you still afraid that your employer was right next to you or not? What do you think? Give us some.
Yeah, that's really interesting. All the comments that I got, we got. Linda Walker identified that the answers were really short. Most of, I guess, if we can, Hispanic community, I guess, or Mexicans or my family, we talk a lot. So we ask one thing and we answer with a lot of words. And this shortness is interesting. So that was right on target, that Ernestina wasn't answer that short, like I have been working here for 3 months or I came 8 months ago, more assertive. It was more with fear than anything. So that the answers are short and there's a lot of fear, and a lot of you comment on that. Also, Sherry said probably he broke her fingers, which is one of the things that crossed my mind. When we did this video, which we have done since like that, Dr. Harrison and I, we don't have a script. We just go like it goes. And I wasn't sure if what I was going to do. And it crossed my mind that actually that the fingers were, he wanted to, the trafficker in this case was a male, wanted to show power and intimidate other people. And so in the door, like crack my fingers, but it could have been also on the field. So people really don't know, but there's one more element about that. I, as some of you mentioned, and I need to see the chat, the exploitation with the mask during COVID, it's outrageous. It's just outrageous that they sell $8 per mask this is, something that I really don't know, but I don't have any doubt that if they give them masks, and yes, that's right. I don't remember who said that, but that was really, really right on target. Or a customers, as it broke a customers, Paul D. Santana. And in general, I think Ernestina was showing a lot of fear. A lot of you comment like he probably is listening. Probably. I thought that the difference between when the man was there, her attitude, versus when he left, she kind of even smiled a couple times. So I believe that, or I tried to establish that he wasn't there in the room. Of course, he could have been listening. Probably he left his phone recording the conversation. We really don't know. But what I felt Dr. Harrison was doing is just open the door and show some human being concerned about not only my fingers, but what else was happening around me, my work situation. And I thought it was compassionate, and I didn't feel as Ernestina, I didn't feel that she had this sense of rush, like hurry up because I have the next, patient here. So those are my comments.
Great. Yeah. And that's really reflected in the chat. We did have some great comments there. Dr. Harrison, would you like to talk a little bit about your overall reaction to this, some of the comments, and particularly I'm thinking about this question of the benefits and the downsides of telehealth.
Absolutely. Thank you, Robin. I would love to address that. And I just personally want to thank all of the people in our audience, all the people participating for their very insightful comments in the chat box. It's really great. We really appreciate that. I do think telehealth is particularly difficult and challenging, but I think in-person encounters are as well, particularly with the ability of people to record or transmit their conversations in the clinical setting. So I think it isn't limited to telehealth, and we really have to be very aware when we're dealing with a situation where privacy really is a big concern. Not that it isn't always a concern, but there are situations in which it's a bigger concern, this being one of them, that we need to make sure that those patient phones are turned off and that we truly have the confidentiality that we need to conduct that encounter. I did see a couple of comments about the length of the encounter and that it seemed to be taking a long time. And part of that is intentional. So when I am dealing with a patient who I think is in a situation that requires more time, whether that is because I think they're a victim of abuse or violence, or for some other reason where it just requires that I spend a little bit more time, I do tend to step back and talk to my staff and make sure that my schedule allows for it. So there's some flexibility in my schedule when I have a situation like that arise, so that patients or other patients are offered the opportunity to reschedule or to wait, and that they're aware that there's sort of an urgent situation going on that's going to take a little bit more time. It's not a lot different than other emergencies in that setting. And I think that patient who initially has such complex needs that they're not trustful deserves that extra time and attention. And so I purposefully talk slower, allow for more empty space so that the patient can answer those questions. This was a role play, and as Graciela said, we never know what the other person is going to say. And you'll see that again in a few minutes when we do the next role play. We do that intentionally because in healthcare, you never know what's going to happen. You never know what the patient is going to say. So we think scripting these, while that might make it more efficient and easier for you to understand and show, is really, it's not an honest portrayal about what actually happens in the clinical setting with real people who have complex needs. I hope I captured all of the questions you posed to me, Robin.
It's great. Hey, now listen, somebody just asked something really good, and I know that we're going to talk about this in several different places, but can you talk about what would have happened if Ernestina's boss didn't say, okay, I can get out of here? I mean, I had the impression that, you had asked enough very, very patient and direct questions about her injury. And he might have said, okay, she's on the level. I don't have to worry about this physician. She's not going to do anything but take care of her hand so I can get her back to work. So he kind of left it pretty quickly. Sometimes they don't, though. What are some of your strategies?
So no, you're absolutely right. Sometimes, perhaps more often than not, they don't leave easily. And so I think this is particularly difficult in the telehealth setting because you don't actually know, as so many of you alluded to in the chat, you don't actually know if the person left. And so, you have to trust that your patient is able to be honest. Not, that's different than willing to be honest, but able to be honest because of the situation. And then you have to measure your words and make some decisions about what's okay and what's not. For me, the most important factor here is my patient's safety and their health. Their health is my responsibility. That's why they come to see me. Their safety is super important for all sorts of reasons that I'm not going to go into. So if he hadn't left, then I would have kept my script and my responses and questions to the health concern at hand. I probably would have dealt with COVID anyway, and I would have made some other arrangements for an earlier follow-up. Perhaps, I would have been present on this imaginary mobile clinic that I created in the moment. And I mean, I know that there are some places that have them. We don't have something like that here in Tallahassee, but we should. It would be a really great service to many communities, not just people that are being trafficked for labor out in Quincy or wherever Graciela was intending for Ernestina to be. Maybe I would have been on that clinic. Maybe I would have sent someone on that clinic or explained to the person who was part of that mobile clinic or part of the testing to ask additional questions when they saw the patient in person. I think that's another really important point of all of this is the healthcare provider is only one part of the team. And we have to be able to work with the rest of our team and have to have trust with the rest of our team. So it isn't important that it's me that asks the questions, but rather that the patient is served and that we tend to the patient's safety and her health. And so it could be anybody, right? It could be a nurse, it could be a victim advocate, could be an X-ray tech, it could be the person administering the COVID test. It doesn't matter who it is. And I would continue to want to follow up in one capacity or another. My favorite is in person whenever possible, to really be able to ask those questions in a way that I felt like we were in a safe setting.
Yes. And, and the other thing that I found that you did, which was, you talked a lot of detail about what her injury was because you don't know for sure you are going to ever see her again.
Right.
So you tried to get as much information. Someone said, well, maybe this could be picked up in the later visit. Very often, if somebody's working in a field or farm or just has no agency, they can't come back to their regularly scheduled appointment. They might not never ever show up at that mobile health visit. So, I think I always get the impression with this that you do a really good job of building trust, letting the patient's agenda control what you're doing, right? And not your agenda or not like the time clock. So anyway, that was really good. So we do have another question that's just come in. Why don't we do this? Why don't we go to the next slide and talk about some of the indicators? And right after this, we will have another video after this next slide. And what we'll do, well, we've got one slide before. There we go. So, and then we'll get Rhonda's question on the other side.
Okay, so what were the labor trafficking indicators that you saw in there? You already mentioned that some of them. I think it's really important, the body language and the fact that she was afraid and concerned. She didn't have papers. Somebody also put that in the chat. And I want to say that sometimes the papers that the traffickers take away is not only papers that like a visa or, something important for United States, but also if they bring their birth certificate from Central America, or if they have a fake social security number, the traffickers take that away. because it's not that it's going to be important for the United States to stay here. It is important for the person. So remember that the traffickers are the ones that are trying to control and make themselves that I am the one who's controlling, so I'm going to take away whatever is important to you. Of course, also you guys mentioned that Ernestina didn't have any idea about the laws. What it was isolated, absolutely. I wish at some point that she mentioned twice that she needed to pay back the money. She was really concerned about that. So that's another indicator, put it together. And sometimes the traffickers also move the victims, so then they don't establish some kind of idea where the surroundings, and they don't get along with people that are around. Like if it is like a forced sex, the clients can come and they can have frequent clients, and that's one of the times in the first time that Robin and I worked, that's how they were escaped, because they got related with one of the customers. You also mentioned identification of her. We don't know about her personal possessions, but clearly she doesn't have any money, and it is really, she's really concerned about sending back money. That's why she came here in the first place. We don't know about how often she has talked to the family. Sometimes if you can offer that, have you talked to your family? We can talk about that later, because we have some initial questions that we can have. And there are Dr. Harrison couldn't see what other things is in her body, but if it is in person, she probably would see, I don't know, like bruises in the arm or something odd. One of you mentioned, I think it was Sherry, that Ernestina looked unkempt and thin. Thank you for that. Trying to be thin, it was enough for the character, but I did put like some kind of black thing here to look like that. But that's good that you check on that what is the status of the person. And I think we can go to the next slide.
Okay, great. Thank you, Graciela. And these are labor trafficking indicators. And just remember, this is not at all a checklist kind of thing. For everything we're talking about, you could see everything on that slide in somebody, and it won't be trafficking potentially, or see nothing, and it is trafficking. So no, these are indicators that you can just take into account. So what we're going to do now is we're going to show you another video, this time looking to our Florida Medical Association colleague to bring that one up. Similarly, this is a video that was done to talk to you about how you might encounter a survivor of sex trafficking. Again, if you could chat during the time of any red flags you see, any things that you think are good or bad during this telehealth visit, and then we'll pick it up on the other side.
Good morning. I'm Dr. Harrison, and I understand that you called for a telehealth visit today.
Yes, I did.
Can I get your full name and age?
My name is Shannon Lively, and I'm 20.
Thank you. And do I have your permission to continue with this telehealth visit? All right, thank you. Are you alone, or is there anyone there with you today?
I'm alone.
Okay, all right, thank you. What can I do for you today?
I think I'm having some problems down there, and I had that in the past, so I think it's happening again.
And when you say it happened in the past, what do you mean? What did you have?
I was diagnosed with an STD, but I don't remember the name of it. I just took some medicine and it got better.
Okay, I'm going to ask you a few questions about that, more detailed questions in a minute. But is there anything else you want to talk about today?
No.
Okay. All right. So some of my questions may seem a little odd. They may seem really personal, but it'll help me to put the picture together and get a better sense of how to best treat you. Okay?
Okay.
All right. And if you feel uncomfortable with anything, just let me know. Okay? So how long have you been feeling poorly?
Maybe like 4 days now, I think. 4
Okay.
or 5 days.
All right. Thank you. And I'm just taking notes so that you know, so that I can keep track. This is my notebook. I'm not writing anything down except trying to keep track of what you say.
Okay.
So can you describe to me a little bit more about what you're feeling? You said it's been about 4 to 5 days.
Mm-hmm.
And
I think I feel hot. I mean, I think I don't have a thermometer, so I may have a fever, I think. And I just, it's like burning and itching down there. And there's like a little, I don't know what you call it. It's like a sore in the area.
okay. And Shannon, do you have your cell phone handy?
Yeah, yes.
Can you make sure that it's turned off while we talk?
Okay. Okay. Okay.
Thank you. So you said you have a little sore down there. Is it on the outside or on the inside?
It's on like, I don't know how to describe it. It's like on the, I guess it's outside.
Okay. Is it on your vulva, the area outside your vagina?
Yes.
The lips?
Yes, the lips.
Okay. And is it on the right or the left?
Right.
The right. And is it just one sore?
Mm-hmm.
Okay. And can you tell me what color it is?
It looks like my skin.
Okay. Is it red at all?
A little.
Okay. And does it have a little blister on it or, okay. Is it pussy? Is it clear?
I don't know. I can't tell. I think it was clear, but now maybe starting to have something.
All right. Have you had sores like that before?
The last time.
Okay. All right. And the medicine that you took the last time, do you remember how many days you took it?
No, like maybe a week or so. I can't remember.
Okay. And did you take it once or twice a day?
Twice a day.
Twice a day. Okay. Do you remember what color the pills were? Okay, that's all right. It's all right. And if I gave you some names of different types of STDs, do you think you would remember what they called it?
I just don't. Yes, you can try. You can
Okay.
try.
And these are just really common things. It's not that I'm suggesting that this might be any of them, but have you ever heard of a yeast infection? Do you think that's what it was?
I had yeast infections growing up, and it wasn't bad.
Okay. How about chlamydia?
That might be. I think I remember them saying there were two things.
Okay. How about gonorrhea?
I think that's the one.
And how about herpes? Have you heard of that?
I've heard of that. I don't know that I don't know if I've ever had that.
Okay. And then what about syphilis?
No.
Okay. All right. Well, so I think we're going to need to do some testing. Do you have transportation?
My boyfriend does.
Okay. And does he know that this is going on with you?
Yes.
Okay. All right. And are you comfortable talking with him about this?
Yes, he actually has the same stuff, so I
Okay.
have something for him too.
Okay. All right. Well, I can't prescribe medicine for him if he's not my patient. But we can certainly get some testing done, and he can certainly make a call, and I can see him in the same way on a different appointment if that's something he's interested in doing.
Okay.
But we do need to get some testing done, and there are ways that we can get both of you tested. Okay. So here's the part where I'm going to ask you some other questions. Okay. And I really appreciate the information that you've given me. It really helps me to try to figure out what's going on. And I think I'm going to be able to help you today. But one of the questions that I have is, you know, whether you're able to use barrier protection when you have intercourse.
What's that?
Like a condom, either a male or female condom?
I mean, not really. We don't really use them.
Okay. And I'm assuming since your boyfriend also has symptoms, and because you describe him as your boyfriend, that you're sexually active with him.
Yes. Mm-hmm.
And are you sexually active with anyone else?
No, I'm not.
Is he sexually active with anyone else?
Yes. Yes, but he loves me. I mean,
I'm not asking about love. I'm just trying to figure out the medical part of it.
okay.
Okay. But you don't have any other partners?
I didn't used to have any other partners.
Okay, what do you mean by that?
Just like, I'm not cheating on him.
Okay, all right. Well, and again, I'm worried about the medical part of it, not the social part of it. Let me ask this in a different way. In the past month, how many different sexual partners have you had?
So maybe 4 or 5, but it wasn't, I didn't have to used to do this, but the COVID has changed a lot of things for us.
It really has changed things for everyone.
Yeah.
So how has it changed things for you?
We just have just had some problems with affording rent, and you know, so we're trying to do what we can to do that, to pay for our bills.
Okay, and so is that what's happening, that you are having sex so that you can get enough money for rent?
Yes, and he said it won't last long. It's just it's what we have to do right now.
And is he doing that as well?
No, he's not. It's just
okay.
me.
Just you. Okay. I'm sorry that that's happening. Sorry that's happening to you, and that this pandemic has put you guys in such a bad financial position. Are either of you working outside of this arrangement that you have?
No.
Okay. What kind of work did you used to do?
Well, I didn't work. He worked. He just, you know, like regular stuff around the city that he finds, just different jobs. But with everybody being inside, it's just, he hasn't found any jobs lately.
Okay. All right. How do you... I'm worried about you, Shannon.
Why?
Because when you talk about this, you sound sad. And when any person's in a position where they don't have control over what they do with their own body, I always worry. This is something that's happening to you that you would not choose to do otherwise. And that's why I'm worried.
Yeah. I mean, I feel I have to do it to survive. And he says it won't last long. So I'm okay with it.
Okay, well, makes my heart hurt, and I want to help you if you'll let me.
What kind of help?
Well, there's lots of different things that we can offer you. even though it seems like it's a temporary thing, the name for what's happening is actually called sex trafficking, where you trade money for sex and someone else is, taking the money to pay for rent or shelter or whatever. And there's a big national organization and some local organizations that can help young women like you when they're ready for help.
But I'm not like those women. I heard of this. This is my boyfriend and we love each other. And
Okay.
I don't know. I don't think that's me.
Okay. All right. Well, there's all kinds of other help that we can give you, food, clothing, shelter. If rent is a problem and food is a problem because of not working, there may be all kinds of other assistance packages that we can offer you. Would you be interested in speaking with a social worker here on as part of this visit?
Okay.
To see what kind of help we can get for you?
Will my boyfriend know?
Not unless you want him to.
Okay, because he doesn't like handouts.
Okay. Well, and this is all your choice. You're an adult. And even though I'm really uncomfortable with what's happening to you, I don't want to take away your right to make your own choices. Okay. So let's go ahead and get a social worker, and I can introduce you. Okay. And then I will give the two of you some privacy so that you can speak without me being on this call. Okay. In the meantime, I'm also going to make arrangements for my nurse to contact you so that we can get some testing. And what I'm going to have to do is draw a little bit of blood. I'm going to have you give us a urine sample. And so we're going to send you to the lab so that we can test for which kind of STD you might have. The urine sample will test for chlamydia and gonorrhea. The blood test will test for syphilis and HIV, just to make sure, okay? And then I will call you with those test results in just a couple of days, and we will get some treatment for you, okay? But my nurse will call you after this telehealth visit is over to make those arrangements for you, okay? And then once we figure out what's wrong, we'll get some antibiotics so that we can get this taken care of. In the meantime, if you can get access to condoms and use them regularly, that will help prevent you from getting sexually transmitted infections.
Okay.
Okay. So I'm gonna call the social worker, and you can talk to her about whatever other needs that you have, and see if she can help you with a few of the things that are really causing you some strife during the pandemic, okay? And I am here for you whenever you want help with anything, okay?
Okay, excellent. And thank you so much, Dr. McCord and Dr. Harrison, for doing this video. We so appreciate you doing it. And let's take a couple of minutes now. And Jasmeka, Dr. McCord, may I ask you how you felt doing this, and to get some reactions from you about how you felt being interacting with Dr. Harrison? It seemed you both did an incredible job.
Yes. I watching this back, I just enjoyed it very much, in a sense that it touched on so many different things that are important when identifying victims and interacting with the health care provider. So we talked about a lot how, it could be runaways and people who are homeless and vulnerable populations. But in addition to those things, it can be just regular relationships. And going back to not having a lot of time doing these interactions, it's like you could have chalked this up to, oh, this is just another young adult with an STD, give them their antibiotics and send them on their way. But because Dr. Harrison took the time to, delve into things that just didn't seem quite right, there was nothing overall that I was trying to portray that was super concerning in the beginning. But once she started asking more questions, that's when, the character became a little bit more like flustered and, trying to defend herself on different things. So just coming from that perspective of trying to be defensive and show that there was something else kind of going on, clued her in to ask more of those questions. So it was interesting on that point of view, but I'm so happy that she just kept probing to get the full story out. You can see it took a little while in the beginning, but then once it got going, we saw, okay, this is the big picture that was going on here. So it was an interesting role to play, but I think we touched on some important things.
You bring up so many important points in terms of vulnerability, especially during COVID. It could be anything of any socioeconomic status, et cetera. So we're going to do this. And we do have, we had a couple of questions and comments. First, I want to just really acknowledge again, everybody's excellent observations. And I know that Rhonda had a question and a comment earlier about how do you, again, separate the patient from a potential trafficker, boyfriend, abuser, mentioning whether or not somebody has a female complaint or other things. I know that Dr. Harrison will be talking and probably you too about how you do that, how you separate the parties and how important that is if possible. So let's move on in the presentation and we'll continue to get to your questions and observations. And we'd like you to refer back to those scenarios too.
Thank you, Robin. And I once again want to thank everyone who is entering their comments and asking questions in the chat box. In the absence of an in-person presentation, which of course we would all prefer, just like we prefer in-person patient interactions, I love the interaction of the audience. So thank you so much for that. I'm going to talk just very briefly about sex trafficking indicators. So in this situation, I want you to imagine yourself in that clinical setting and think about what things might alert you that a patient that you are serving might be a victim of human trafficking. So as Robin mentioned earlier, the traffickers are always one step ahead of us. They are always thinking of different ways to control people, different mechanisms for branding people, if you will. You'll see on this slide, there's a couple of photographs of a woman who was branded by her trafficker, and this is an actual sex trafficking victim from the Tampa area. And you can see branding on the neck and then a different branding on the inside. It's actually two different people. Recently, the traffickers have been inserting RFID tags and then telling their victims that they can GPS locate them with the RFID tags, which is not true. At least it's usually not true, although technology is advancing, and I would imagine that shortly that will be widely available. RFID tags are the little chips that we put in our pets to be able to locate them. So if they scan, then they can identify the owner, and then that pet or person could be returned to their owner, if you will. So just be cognizant of there are many ways to brand a person, and don't automatically assume that a patient is, unstable, having hallucinations, and that the story that they're telling you is not real. It may very well be what's actually happening. Dr. McCord mentioned earlier the issue of having an unusually high number of sexual partners, our history of sexually transmitted infections. Especially in our early clinicians and learners, they're sometimes a little bit shocked, maybe perhaps even more in my generation of healthcare providers, people who have been serving a certain clientele for a number of years and get surprised by a high number of sexual encounters. This is my plea to you to not be surprised, to not show the patient any judgment or any shock, because that will shut them down faster than anything. My ask to you is that you consider the why behind that answer. So why does that person have a high number of sexual partners? Why do they have a history of recurrent sexually transmitted infections or new sexually transmitted infections? Do they have the agency to be able to say no, to choose their own sexual activity, or is someone forcing that upon them? Jasmeka already talked about seasonally or situationally inappropriate clothing. It's a little bit harder to spot in Florida, where the weather is warmer, maybe not so much in the winter, but just think about whether or not that seems appropriate. Whether, we're talking about sex trafficking in this situation, but it applies to labor trafficking too. Somebody mentioned that Ernestina, Graciela's character in the labor trafficking, looked a little disheveled. And so think about their appearance and what that might mean, without making a judgment, just to ask the questions. A victim of sex trafficking, particularly if they've been in the life for a while, may use rough language or terms that are common to the sex industry. And so that can be a cue that this person is in that environment and that language has become normal. It doesn't mean that it is, but it is something that you might watch for to ask more questions about. And then, as Jasmeka said earlier, you know, anyone who is under 18 and involved in the commercial sex industry is a victim of sex trafficking just by definition. But if you see that patient who is coming in saying they're 18, 19, 20 years old, and they look 11 or 12, trust your instincts. Look it up. Check the FBI missing persons database. Ask other questions. Someone mentioned in the chat box about verifying a date of birth rather than just an age. That's a great idea. Anything that you can do to ask an additional question that may provide a slightly different answer. So you'll notice in that video that we just played, when I was asking questions about sexual history, I reframed them in a different way because I was not convinced that the answer that I got was the actual true answer. So by reframing it, you know, I was able to gather a little bit of additional information. So, you know, just be watchful for those signs. All right, so the next thing I want to talk about is behavioral indicators. And I absolutely believe that this is the way that I am most able to identify patients who have a story, a backstory that is concerning. I won't necessarily know what it is until I start asking questions. But that patient that seems anxious or fearful, who doesn't make good eye contact, who maybe they seem unduly subordinate, and they're saying, yes, ma'am, no, ma'am, that sort of thing. You know, that could be great manners. It might mean something else. Just, you know, you're the one that's in the situation, use your best judgment. You might have a patient who's hypervigilant, checking their cell phone all of the time, getting text messages, getting anxious when they get a buzz because there's another text message. Again, you know, you'll have to use your own skills to decide whether you ask the patient to turn the phone off, whether you address it directly. I tend to be very direct about things so that patients don't sense there's any hidden agenda. I'm just very clear about my questions and about my responses. I do my best to do that. You might see a patient who has a depressed mood, who there's evidence of self-harm behaviors. A patient who, sex trafficking victims have a high rate of suicidality. So if you've got a patient who's depressed and suicidal, you know, you want to know the story behind what happened. And again, these are just indicators. They don't necessarily make a diagnosis for you, but they tell you that there's something more to this story. And it's our job as we serve those patients to really ask those hard questions. Graciela, I believe, mentioned earlier a little bit about substance abuse, and I just want to touch on that again. Addiction is incredibly common with victims of sex trafficking. Some of them are already addicted and using substances for a variety of reasons before they come into the life. But substance abuse and addiction are also common tools for traffickers. They will often give patients or give victims, excuse me for getting my language mixed up there for a second, substances to keep them controlled, to allow them to be able to use them and traffic them frequently. So substance abuse is a hard issue to deal with. It is not cut and dried. We don't want to be blaming the patients that are using substances. We need to ask that backstory and the why. And Dr. McCord mentioned earlier that bit about not knowing where you are, not knowing what city you're in, what address. Victims of sex trafficking in particular have this sense of loss of time. They are sometimes held and worked in the same environment. And so, you know, there might not be windows. They may be in a trailer somewhere. They may be moved from location to location, might not know where they are, what day it is, how many months it's been, what time of the day. I mean, it's just a crazy life. And I could go on about that, but we are running out of time, so I'm going to try to move through this a little faster. All right, so more on the control, and there were several comments about that through both role plays. But and Robin had asked earlier about, how do you separate people? And so I'm going to take a little bit of time to talk about that here. When you're in the clinical setting, or even in the first role play with Graciela playing the role of Ernestina, there was obviously a controlling person. And so if you have any patient interaction where there's another person that's accompanying that person and they seem to be controlling the narrative, controlling what happens, you should worry. We want people to have agency over their own healthcare, over everything in their life, to the extent that that's reasonable. Maybe not for a 5-year-old, but you get the picture here. And so if they're accompanied by a controlling person, it should just alert you to the fact that there may be something more going on there. If they won't allow the patient to be seen alone, that is a big red flag for me. If they interrupt the patient, don't allow them to answer the questions, they interrupt them or correct them when the patient does answer questions, that's very, very concerning. And as you saw in the first role play, Graciela actually turned to her trafficker looking for, what am I supposed to answer here, right? And so if you've got a patient who is referring to another and, wondering, what am I supposed to say here? They'll often come to a healthcare appointment, regardless of what type of trafficking we're dealing with, or even just violence and abuse in general, come to a healthcare appointment with a script. This is the story. Don't vary from that story. And if you ask a question that's not part of the script, you're going to have that split second of silence where they're trying to figure out what they're supposed to say. That is your in. That is when you ask more questions. When you have a sense that there is a person who's controlling that other person, it's absolutely imperative that you see that patient alone, that you separate those individuals somehow. If you're in person, it's easier because there's always paperwork to be filled out, tests to do, a urine sample to collect. And as I said before, this is a whole team effort. This is not you individually. So perhaps I want to talk to the person who's controlling just to get a few more questions answered. They really like that because they like to be in control. And so if I say, hey, could you just come over here and let me ask you a few more questions? Then I would have my nurse go in the room and ask the harder questions of the patient and establish that trust. Because there's nothing special about the way I ask questions. Anyone can do that. And so, however it works in your team, identify those people that are really invested in making sure that we get help for these patients and who are really, very, very trusting individuals, people that patients will come back to, whatever that role works for your setting. So we were going to talk a little bit about telehealth and human trafficking. Robin, do you think we've covered this sufficiently?
I think we've covered it, absolutely.
Okay, all right.
So thank you so much, Dr. Harrison. We're going to be talking about the approaching to the patient. So we can go to the next slide. So what is the victim's perspective? I just wanted to make sure that you consider if the person that is in front of you have slept well some certain hours, that if they have eaten consistently, if they are thirsty, the language barrier is a big problem. We have had people from Mexico and Central America that don't even speak Spanish. They speak a dialogue. So we need to be very careful about what and who comes to do the interpretation and translation. That person has to be trained on human trafficking too. And I want to take the time to address a couple of good points that Olga and Constance, I hope I am pronouncing the name right, that, for example, with Dr. McCord's character, that character did not feel like a victim. And it was almost offensive, like, no, he loves me, I love him. And that's where we call right there in the slide, they might not want to or probably able or understand the situation, so they cannot be rescued. They probably are in the role of, this is my boyfriend and this is, somebody that cares about me. So then, even though you see the situation, this person is in the middle and you cannot force that to get to that point. I think they have to realize that by themselves. It's really frustrating as an advocate and as a probably physician or whatever your position is, but that's what it is. And
so thank you, Graciela. We're kind of running out of time, so I'm going to hurry through these slides just a little bit. So just to sort of back up and put yourself in the clinical setting. So a general approach to how to care for these patients. And again, you don't know the story before you begin. So I want to emphasize again that you will always interview and or examine the patient alone. If you don't have an opportunity to do part of the encounter alone, then you don't ask the questions, because you could put your patient at greater risk for being harmed or severely injured or even death. As Graciela was saying with the previous slide, the importance of communicating in the patient's own language is incredibly important. So use a trusted and reliable interpreter, not someone who's connected to the abuse or to the patient in any way. I talked before about checking the missing persons database if you have a high suspicion. That doesn't need to be you. You can assign that to somebody else on the team while you're continuing to provide care. Some of these patients, because their needs are so complex, while you have mentioned confidentiality, you need to reassure the patient frequently during the encounter. So this is not a one and done statement. You need to continue to re-emphasize that. And it's important that we're truthful. So don't say things that aren't true. Don't say you're not going to report this if you are. If that comes up and mandatory reporting is required, be honest with your patient about what's going to happen. You'll never see them again if you are not honest with them, and they will not have any reason to trust future healthcare providers. So that's really important. Robin's going to talk about the mandatory reporting in just a few minutes. As you're continuing to interview the patient, just proceed really carefully. Don't pressure them, but just invite them to answer your questions. Reframe as needed and let that patient feel like they're in control of the interview and the examination, and putting the patient's identified agenda first and foremost. You can get to your own agenda if there's time, but it is the patient's appointment and they are the one being served. So just keep that clear in your mind. And again, the patient may not be aware of their own rights. So make sure that you explain things when you can, if you can, about what is available. Graciela, back to you.
So Dr. Harrison did an awesome job, I think, with both characters. And she asked about the living situation, transportation, phone. This is just some kind of ideas that we are proposing for you, just to start like basic questions, attend immediate needs. But also we have another slide where it's the next one, the secondary questions that it depends on the situation. We put it in what questions we ask first. For example, I would say these one of the secondary questions that I would ask to Ernestina, probably at the beginning, I don't know, it depends on the situation, would be, what else do you need to pay back? Because she kept saying a couple times, I need to pay them back. What else is going to be, the food or the transportation or what? And I think,
yes, now we can talk about resources. So everyone, just so you know, this first point is really important. Just to recognize that there are service providers in your area, as well as the National Human Trafficking Hotline. So you are not the service provider, which would be a great relief, but you are the link. Again, making people know that you're assisting, that they're not alone, and that help's available. So let's talk a little bit about some of the needs. And if it's okay, I'll just go ahead and take this next slide as well, just to make sure that everyone knows that The services that are provided by your local programs are truly survivor-centered and trauma-informed. If you need help, contact STAC. We'll help you figure that out. And here are some examples of what we have seen that survivors need. And it could be any of these things and many more, and multiples of these. Of course, remembering at all times that the survivor really is the expert. Know that in terms of steps you take, of course, 911 if the patient is in danger. None of this is a HIPAA violation to call if you do have any of that there and that danger there. And knowing too that you've probably got institutional protocols in place for all of these things. Recognize the National Human Trafficking Hotline number that Dr. Harrison covered in the labor trafficking scenario. And absolutely making sure that if you can, get that follow-up appointment scheduled before the patient leaves the room. Going further into talking about reporting, one of the things I just, there's going to be a quiz after this, so I want to make sure everybody knows this because it'll help you pass the quiz. First of all, understand that as healthcare providers, you have an obligation to report gunshot and life-threatening injuries of anyone, not just people who are trafficked, but anyone that you treat in that county, and that's a call to your sheriff. Of course, there's consequence for failure to report. Know that you might have to, as a healthcare provider, make 2 calls. And that is to say, first of all, recognize there is not a mandatory report that you have to do for all persons at all times on the issue of, quote, human trafficking. Rather, there's this first one. You've got to report anytime you see gunshot wounds or life-threatening injuries. And second, you have to make a report to DCF if you suspect human trafficking of a child or vulnerable adult. Excuse me. And here's your information on DCF. That means a call to the hotline. 96 Abuse is the number there right there on the screen. That and all of these things are true. It's anonymous. They may follow up with you. Understand we've talked a lot about child abuse in those reports in our presentation, but know that vulnerable adults, that's anyone over the age of 18 who can't take care of themselves on a daily basis, is a potential or identified vulnerable adult. They too have been and are targets of traffickers. So please understand you've got 2 potential ways of reporting. There's no mandatory reporting of human trafficking unless you suspect that that person is a child or a vulnerable adult, and that is a mandatory call to DCF. Okay. And Suzanne.
Yeah, so I'm just going to just ever so briefly mention documentation because this is just as important as you close out the encounter to us in our follow-up appointments, to other healthcare providers, and to the patient. So, just be as detailed as you can in your documentation. If the patient discloses, make sure that you capture that in quotations if at all possible. If they don't disclose, make sure you document your concerns. Include detailed physical exam findings with photos or drawings where indicated. And I think Jasmeka mentioned earlier the importance of doing a total body exam to look for other injuries. Include your concerns, as I mentioned, and then document that follow-up plan, including any resources that you provided and the safety assessment that was done as part of that encounter. It's incredibly important that you make that follow-up plan before the patient leaves the room. We don't know who's in the waiting room, so you don't want to send them to another location to make that follow-up appointment because their abuser, their trafficker could be present, or someone else that's connected might be in the waiting room. So it's easy enough with the computers and electronic health records to do that in the room with the patient. There are all kinds of benefits for this, and I'm, in the interest of time, just going to keep going. Robin, I think I'm back to you.
Okay, taking action and advocacy. This is where we just want you to connect up with a ton of materials that are out there. You can see some of the things you could do now. Developing an institutional protocol, knowing local resources, and, Dr. Harrison, I think you did a great job in talking about how the whole team needs to be involved and educated on this issue. Okay, next slide. So know that the Department of Health, as well as STAC and many others, have the signage that has been required as of the beginning of this year. That's posting of the National Human Trafficking Hotline. in English and Spanish, and having that be available in your workplace, not necessarily in the waiting room, but in those places where you have, congregations of staff, like the break rooms and restrooms, et cetera. So we've got signage, and so does our Department of Health. So check out their information. This is a brief review for you to know that the 96 abuse number is here, National Human Trafficking Hotline number. This is STAC's number. That's both talk and text. And of course, at all times, calling 911 if there's an emergency is vitally important. And I should say we're about to post also the CEU information. We're going to post the links to the quiz and to the evaluation before you do your next slide there, Suzanne.
So I can go back to it. I was just going to put the CE credit information up on the screen for people.
Okay, great.
Are we posting it in the chat?
It is in the chat right now for everybody to grab directly from the chat. Okay. So please do that. And we would like you to get this done as soon as possible so we can get this reported into CE Broker.
Absolutely. So I just want to thank everyone for your kind attention this morning and all of the questions again. I invite you to think about what you recall about your own patients. I know as a healthcare provider, I look back on my interactions with patients, and I can promise you that I can identify patients who may have been victims of human trafficking in retrospect that I did not pick up on at the time. So I want you to be forgiving of yourself for perhaps missing things because you didn't know what to look for. You didn't know what to do about it. You didn't know how to respond. I think we all do the best that we can with the tools that we have. And so what this is about this morning is really just providing you with an extra set of tools. It seems as though our audience and our participants this morning are very aware of this issue and were able to identify some of the red flags as they were watching those scenarios. So are already very educated and would do a good job with patients that they served. But think about what you did, what you asked, what resources you provided, and what you might do differently now after this training event.
Absolutely. And then just to mention, Suzanne, thank you so much. Jasmeka, Graciela, this has just been tremendous. And we're getting lots of thanks. I think we've covered all the questions actually during our presentation as they came up, because you have been such a wonderful group of attendees today. So thank you for that.
Robin, I'm sorry to interrupt. Yeah. It seems in the chat that there's they cannot cut and paste.
That's right. Yeah. So look to the posting in the chat. So you see a posting from STAC to everyone that has the 2 links. We can put those in there again. It might be difficult to do that, if not impossible, from the actual slide. Please go ahead and click on the links that are in the chat, everyone. That was posted from STAC to everyone. There's a link for taking the quiz and taking the evaluation. Yeah, sometimes it's tricky with these slides to get that done. And let me also put in, actually, if I could ask Alex to put our contact information into the chat again, I think we can probably go to that slide, Dr. Harrison, on our contact information. If anybody has any questions, please feel free to get in touch with me, Robin at surviveandthriveadvocacy.org. And that will be my pleasure to connect you up with these links as well if you're not able to pull them up now. Again, I want to thank everybody for being part of Imagine Freedom 2021. This is our first program of our 3 days of local community activity. We're very, very encouraged and honored by all the participation today and from so many in our community that have supported STAC. We will continue to bring these programs to everyone free of charge, but want to just put our website into the chat there. I think Alex can do that for us. If you do feel so moved and you would like to contribute to help us sustain our work, we would greatly appreciate any contributions you could send our way. We're honored to do this work. We're honored to be supporting the survivors that we work with and be linking arms with the healthcare community in particular over this issue. And again, let me close out by thanking our presenters, Dr. Harrison, Dr. McCord, Graciela, and also a big, big round of thanks to the Florida Medical Association for your generous support of this program and of Imagine Freedom 2021. Can we just see if there are any final thoughts or questions?
Yeah, there is. They keep asking if we can provide this presentation. It will be in our website, correct?
Yes. If you go to the surviveandthriveadvocacy.org under educational resources, and maybe Alex can put that in the chat as well, or you can. We're going to be posting this exact program, also available for CE credit. It'll take us a little while to do that, so give us a couple weeks for us to do that. It will be available. And go ahead, please. I thank you for mentioning those, Graciela, that we've got tons of resources. We do trainings every month. We've got lots of news, and we've got lots of videos for you to share with your colleagues. And we really would appreciate you doing that. So thank you all. And I think that would close us out. We can probably let you all know that we are at our end time. But as we do this, are there any comments or things that you all would like to share now about this program, or to close us out? Okay, I think that will do it. And again, thank you everybody for this time together. Enjoy the rest of your day and your week. Bye-bye.